So we continue with the second presentation of the TEVA in order to avoid microphonia. Okay, Straho, we are hearing you, Dr. Vasiliev, we are hearing you, and we are ready to listen and to see your presentation. Go ahead.
Okay, thank you. So the presentation is about the clinical experience with Ticagrelor in high-risk PCI patients. So basically, the ESC guidelines of antiplatelet therapy after PCI in patients with acute coronary syndrome are pretty clear. If everything is okay, there is no bleeding risk, we should have a combination of aspirin with P2Y12 inhibitor for 12 months of DAPT. And if there is a high bleeding risk, we can reduce the duration of DAPT to 3 months and even 1 month. And then, of course, continue on SAPT, which can be done with aspirin only or P2Y12 inhibitor only. The use of clopidogrel is associated with a reduction in the risk of bleeding, which is well, not necessary, but pretty good for patients in high bleeding risk. But keeping in mind that clopidogrel is not first-line therapy in these patients, ticagrelor and prasugrel are the first-line treatment on top of aspirin. Of course, the rationale for retreatment with P2Y12 inhibitor in patients with acute coronary syndrome is weak in the area of rapid access to early invasive coronary angiography. Even in our cath lab and in our hospital, we don't give the DAPT before stenting. We do it after the procedure is done. Then we give the patient the aspirin and a loading dose of P2Y12 inhibitor. So yes, you see both ends are bad, high risk, high ischemic risk, and high bleeding risk. So deciding on how long will be the DAPT therapy and what exactly will be the DAPT therapy is a key part of the treatment. There are some scores, you know, the high bleeding risk, advanced stage, kidney or liver diseases, active cancer, anemia, low platelet count, of course, prior bleeding, most importantly, a major bleeding, and the use of oral anticoagulants, of course, and NSAIDs, drug interactions, all the surgery, big surgeries, traumas, and risk of falls. And if you have one major risk or two minor risks, the criteria is this is high bleeding risk, and high ischemic risk is a very complex coronary artery disease as determined by the physician, and maybe the score that we can exactly use is the syntax score and, you know, the clinical condition of our patient. Yes, this I already said, the predictors of ischemia and the predictors of bleeding. It's important that many of our patients who have predictors of ischemia also have not one but many more predictors of bleeding, so it's a very complex decision in this kind of patients. Sorry, can we go to the next slide? Up. Now I'll go back a little bit. Yes, excuse me. So yeah, we have modifiable factors, and non-modifiable factors. The modifiable factors are smoking, diabetes, inflammation, drug interactions. These are all connected to the patient and to the physician in order to control them. That's all. I already said it. So what strategy to use? The most important question. Strategies such as P2Y12 inhibitor only, monotherapy without aspirin, de-escalation from a higher dose of the P2Y12 inhibitor, or de-escalation from a more potent to less powerful therapy agent are increasingly present in the guidelines recommendation. Even we have a lot of patients or monotherapy and early de-escalation of the therapy, and this is very useful if we have a ticagrelor, if we use ticagrelor, because we can de-escalate the dosage there according to the guideline. In patients who do not have high hemorrhagic or high ischemic risk, the use of target antiplatelet therapy may be considered, and the most valuable and individualized approach, while unguided use of clopidogrel after 1 month of standard DAPT and monotherapy with ticagrelor after 3 months of standard DAPT are alternative options. And patients who do not have a high hemorrhagic risk but are at high ischemic risk may benefit from 12 months of DAPT, which can be even extended if there is a need and the clinician is decided to do that. Of course, the radial access and lower dosage of aspirin, like 75 milligrams, are shown to have a reduced bleeding risk, and also using aspirin 75 milligrams or 100 milligrams are connected with almost the same ischemic risk. So the dosage is not that important, but 100 milligrams may be connected with more bleeding risk. You know, of course, the usage of PPI for reducing the bleeding risk from the gastrointestinal tract, the DAPT de-escalation and less DAPT duration, as I already said. The approach here, we already said that. So Ticagrelor. Ticagrelor is the one P2Y12 inhibitor that we can use. It has benefits from pleiotropic and cardioprotective effects. It improves the coronary blood flow, and there is reduction of myocardial necrosis after ischemic events. Also anti-inflammatory effects. And ticagrelor has benefits related to lower mortality over other P2Y12 inhibitors. It's not shown here, but there is even a study showing the comparison between ticagrelor, prasugrel, and clopidogrel, despite of the high ischemic and high bleeding risk in the patients, just comparison in acute coronary syndrome, and there are no ischemic events, so no in-stent thrombosis and restenosis in the patients who had taken ticagrelor, despite of the continuation of the DAPT. And ticagrelor is recommended for all forms of acute coronary syndromes, of course, regardless of the planned approach, invasive or conservative, and independent from the coronary anatomy also. As I already said, it's in the guidelines, and ticagrelor inhibits the platelet aggregation, suppresses the inflammatory response, improves adenosine function, and has cardioprotective effects, of course, pleiotropic effects. And here is a case report from our hospital. A very complex patient, 68 years old, male, admitted to the hospital in pulmonary edema. From the EKG, he was with atrial flutter, with high ventricular rate. You can see the echo. It was left ventricle with diffuse hypokinesis, apical akinesia, ejection fraction around 15%, maybe even less because of the moderate mitral insufficiency and severe tricuspid insufficiency with, as you can see, a TAPSE of 10 millimeters. So he has not only left ventricle dysfunction, but total both ventricles cardiac dysfunction, and even pleural infusions in both sides. Because of the clinical symptoms of pulmonary edema and very high enzymes for myocardial necrosis, the patient was directed to the cath lab, where a critical multivessel disease was seen. Here is the diagnostic caudal view you will see from the angio. So critical circumflex stenosis, critical LAD. There is even ramus intermedius, which is also critical in stenosis. And here you can see the diagnostic of the right coronary artery, which is split self-observatory. And so in this high-risk multivessel patient, we decided to do a PCI as a life-saving treatment in the clinical condition of the patient. So you can see the wires introduced from ABU into the LAD, the circumflex, and the first marginal of the circumflex. After that, we did firstly a predilatation of the first marginal with a balloon, and After that, another predilatation from the circumflex to the first marginal, with implanting of a stent. You can see the size of the stent in the circumflex artery, and of course, spot of the stent in the circumflex. Here you can see the result in the circumflex artery. Oh, pretty good blood flow into the circumflex into the first marginal. After that, we did a direct stenting of the ramus intermedius. I'm sorry, I'll go back a bit. Yes, here is the direct stenting with Desonix. After that, kissing of the LAD and ramus intermedius. And here you can see the result. Nice symmetry, blood flow into the vessels. And also here. So this patient was recanalized. After that, on echo from the peripheral arteries, he had also peripheral artery disease, for which he came again. It was revascularized there also. And 4 months after this high-risk procedure, he is very good with very good functional status, basically no heart failure symptoms, with ejection fraction of 50. So, intact right ventricle function also. So basically, there's a saved patient which was on Ticagrelor 2 times a day, 90 milligrams. On top of that, with aspirin, and because of the high ischemic risk in this patient, we are still continuing the DAPT and following up the patient. So thank you.
Thank you, Dr. Vasilev. It was really a very good case illustrating what we have discussed a couple of minutes ago. So some questions or comments? Any more?
This patient had atrial flutter.
What?
Yes. And this
is
can be
yes.
yes. This can be problem with Ticagrelor therapy for after.
Is it atrial fibrillation patient or not?
Yes, so the patient was
Yes.
admitted in atrial flutter, which immediately after recanalization converts into sinus rhythm, and because of that we did a triple therapy while he was in the hospital, because he was here for like 10-15 days in the intensive care unit. But after that we decided to not give him any anti-ischemic, no anticoagulants, because we connected the condition with the pulmonary edema and the critical condition of the patient. So he's in sinus rhythm and no atrial fibrillation and atrial flutter anymore.
Like we have commented yesterday, one of the predictors for atrial fibrillation is the acute coronary syndrome. So it's very nicely demonstrating what we have discussed yesterday. Thank you, Dr. Vasilev. It was a good presentation. Thank you so much. And in fact, probably you can go to the patient that we have just treated with the in situ fenestration. I have understood that the patient himself, he wants to tell us hello. So please tell me, and me, or probably better to Dr. Stankov, please share with us in case you are with the patients for 30 seconds to have last notes from here. From him. Okay,
Yeah,
thank
yes,
you once again. Thank you.